everyone. My topic is factors affecting compliance to anti-glaucoma medications during COVID-19 and its effect on progression. I have no financial interest. Second wave of COVID-19 hit the country during the late of March 2021, and in order to curb down the unprecedented spread of the virus and the resultant fatality, country went through recurrent lockdown and travel restrictions and mass quarantine were implemented throughout the country, hugely affecting the treatment of chronic diseases like glaucoma. Even before COVID-19 pandemic, adherence to anti-glaucoma medication has been an issue, and the pandemic had led to worsening of the situation. Aim of this study is to find those factors that affect the compliance of anti-glaucoma medications during second wave of COVID-19 pandemic and progression of the disease due to it. It was an observational cross-sectional study conducted at Tertiary Eye Care Hospital in a Cuttack district of Odisha from December 2021 to June of 2022, including patients of primary open-angle glaucoma who are on anti-glaucoma drugs more than 18 years of age, excluding the patients who are newly diagnosed cases of glaucoma, secondary glaucoma, primary angle closure glaucoma, history of glaucoma surgery, and patients who were non-compliant before the second wave of COVID. Patients were examined under two parts. The part one consists of a multidimensional questionnaire containing demographic and clinical data and questions regarding barriers for medication adherence during the pandemic. And the second part consists of examination including best character visual acuity using Snellen's chart, IOP reading with Goldman applanation tonometry, visual fields by automated perimetry for VFI, and RNFL thickness by OCT. Total number of patients examined including the fulfilling the inclusion and exclusion criteria were 220 eyes of 220 patients. Out of 220 patients, 130 patients were found to be non-compliant to anti-glaucoma medications. That is 59.09% patients were non-compliant. 143 patients belong to more than 60 year of age group, 132 were males, 58% belong to rural areas, 63% patients had to travel more than 50 kilometers from the hospital, 68% belong to lower socioeconomic status, and 78% were using more than 2 anti-glaucoma medications. The most common barrier for compliance to medications during COVID-19 pandemic in our study was found to be financial difficulties, followed by longer distance to hospital, unavailability of the transport, and non-availability of the medications as some other factors. Now, statistical analysis was done using SPSS software, and paired sample t-test was used to compare the best corrected visual acuity, intraocular pressure, RNFL thickness, and VFI before and after second wave of COVID-19, and the mean difference between all the parameters between both the groups were found to be statistically significant, that is p-value of less than 0.001. The results are shown in the slide. In our study, 59.09% patients were found to be non-compliant to anti-glaucoma medications, whereas study by Akan et al. Found a low non-compliance rate of 28.4%, whereas study by Rizwan et al. Found a higher non-compliance rate of 80.5%, whereas study by Subhadra G et al. Found a similar non-compliance rate of 57.3%. The main reason in our study for non-compliance was financial difficulties, whereas the studies by Subhadra et al., Somi et al. And Rizwan et al. Showed non-availability of the medication as the main barrier. 80.76% patients in our study had raised IOP, 24.61% has decreased RNFL thickness, and 12.30% patient had reduced VFI than pre-COVID time as an effect of non-compliance, whereas study by Somi et al. Showed 81.25% with raised IOP and 78.13% with reduced VFI. To conclude, COVID-19 pandemic has caused a statistically significant increase in the rate of non-compliance to glaucoma medication, and this non-compliance has resulted in statistically significant increase in intraocular pressure and decrease in visual acuity, RNFL thickness, and VFI compared with the pre-pandemic situation. So teleophthalmology should be the future to meet the need of glaucoma patients during the pandemic. This is the questionnaire. Thank you. Sir? Yes, sir. Sir, no, it was not control, sir. It was before the second wave of COVID-19. We take all the records from our electronic data and from the previous prescriptions. Then, according to that, the RNFL thickness of the superior, inferior, and the average thickness were compared before the COVID-19, second wave of COVID-19, and after that.
Yeah, that is the study group. Now you have shown that 40% of the cases have not progressed. You have said 60%, 59.09.
Yes, sir.
About the 40%, was the RNFL thickness the same as
So we
pre-COVID,
have
or
not,
was there a deterioration?
no,
so
sir,
that is what is control. So
okay.
that is the study you must do. Like In the control group, where there was no progression, what was the RNFL
Okay.
variation? And where the disease has progressed, what is the difference between the RNFL progression?
Okay, sir. I had only taken the patients were non-compliant as the group, and studied.
So basically, the compliance factor was the main
Yes,
stay
sir.
of the study
Yes,
rather
sir.
than the progression effect on progression.
Okay, sir.
Okay, thank you.
Because actually, whenever you're taking, you'll have to have a comparative study
Okay.
in this case because glaucoma itself is a progressive disease. Even with compliance, you cannot be sure whether the progression is happening or not.
Okay, ma'am.
So this study becomes a little bit biased because you're taking only non-compliant who are not on medications. Even those on medications may have progressed.
Okay, ma'am.
So that would have been a comparison. That would have given you better. Actually, think whether the medications being offered for a short period. This was only a short period. Epidemic was only there for a probably maybe the exact lockdowns and everything was only for 9 months, 10
Yes, ma'am.
months.
Yes, ma'am.
So does 9 or 10 months of not giving medications does it actually cause harm? And then maybe you could have categorized your patients into the stages of glaucoma, mild, moderate, and severe. Because
Okay,
every
ma'am.
stage would not advance so much.
What I suggest is you have got a good data. You have an excellent database. 220 patient study is very good. Go back and do this study.
Okay, okay, sir.
You
Thank you.
have the data. You have to just interpret it.
Okay, sir. Thank you, sir.
आप यहाँ पर नेक्स्ट खोल दीजिए डॉक्टर अंकिता का खोल दीजिए सिस्टम में है
Okay. Okay, good afternoon everyone. I am going to present my case report, that is the management of non-filtering restrictive bleb. I have no financial interest. Bleb dysesthesia is a syndrome caused by bleb interfering with the normal eyelid function and tear film distribution. The symptoms are ocular pain, discomfort, burning sensation, foreign body sensation, and excessive tearing. Bleb dystocia is a rare complication of glaucoma filtration surgery, and it is hypothesized that a hypocellular tissue response probably related to use of antimetabolite creating a avascular bleb that can retreat at larger size. Regarding the treatment, it can be managed conservatively by lubricant and set eye drop, bandage contact lens, bleb needling, compression suture, anti-yag laser treatment, and autologous blood serum. But surgery is the effective treatment, and bleb limiting conjunctivoplasty is a simple and very effective method to limit the bleb extension. Here we report a case of large interpalpebral extended bleb managed surgically by blade limiting conjunctivoplasty. So our objective is to report a case of large circumferential dystatic bleb and its management. This is a case of 56-year-old female presented with the complaint of swelling in the right eye for last 3 to 4 days associated with the foreign body sensation, itching and watering. Swelling was painless, progressive in nature and not associated with the redness and discharge. She was a non-case of primary angle closure glaucoma and was treatment for last 3 years and underwent uneventful right eye trabeculectomy with MMC 2 months back. Her visual acuity was 624 in the right eye and 612 in the left eye. At the presentation, the IP was 24 mmHg in the right eye and 80 mmHg in the left eye. She was on topical AMG in both eye, 2 drug that is the brimonidine combination, timolol combination in the right eye and 4 drug in the left eye. She had advanced cupping in both eyes. CD ratio was 0.09 in the right eye and 0.08 in the left eye. This is the bleb, this is the diffuse circumferential bleb extending from the 11 o'clock to 6 o'clock. So we prescribe the frequent instillation of lubricant and non-steroidal anti-inflammatory drug along with the AMG and planned for bleb limiting conjunctivoplasty with the compression suture. This is our surgical technique. We just video is not working. Okay, we just incise the conjunctiva and the tenant capsule up to the scleral blade, and the cut end of the sclera we just suture separately both the end of conjunctiva and tenant capsule with the sclera separately, leaving bare sclera. So in first post-operative day, the IP was 20 mmHg and the bleb morphology was S2, E2, B3 and S0. And we noticed there was a regression of interpalpebral bleb. On the second post, that is on first week, second post-op day, the bleb morphology was S2, E2, B2 and S0, and we can see the regression of the interpalpebral bleb. On third post-op day, that is the fourth week, the IP was 60 mmHg with the bleb morphology S3, E3, B2 and S0, and there is a complete re-observation of interpalpebral bleb you can see in this picture. So regarding discussion, bleb dystocia is an uncommon complication of filtration surgery, and it is hypothesized that MMC form a smooth surface of subconjunctival connective tissue in dystatic bleb that preventing adequate healing of conjunctiva to the underlying episclera and accumulation of fluid in interpalpebral area. Here we hypothesize in this case, along with the intraoperative MMC, excessive amount of subconjunctival gentamicin and dexana was injected inadvertently in the inferonasal quadrant at the end of surgery. It might have created a subconjunctival tract that communicating with the superior bleb leading to its extension. Regarding our surgical management, it is originally described by Rahman and Thaler, and it is supported by Anis et al. In his case series with favorable outcome. And another report, Holmes DP also reported the favorable outcome, but in place of suture they use fibrin glue while doing the bleb limiting conjunctivoplasty. So our conclusion is bleb dystocia following antifibrotic enhanced trabeculectomy is not very common, but it causes significant decrease in quality of life. Subconjunctival injection of gentamicin and dexana near to the bleb or an excessive amount may contribute interpalpebral extension of the bleb. So surgery is the only effective treatment, and bleb limiting conjunctivoplasty is the simple and very effective method to limit the bleb extension. These are the reference. Thank you.
I have two questions. This is the first surgery for the patient, first trabeculectomy for the patient? This was the first surgery for the patient?
Yes, ma'am.
First glaucoma filtering surgery?
Yes, ma'am.
So why did you choose the supratemporal quadrant? Because I think you have started the surgery in the supratemporal quadrant.
Yes,
Why was the supranasal quadrant? Because that is the first, normally in a nave eye, which is an untouched conjunctiva, we usually touch the supranasal quadrant as the first surgery. Why was supraconjunctival? And secondly, what was the mode of application of mitomycin C intraoperatively? Did you give as, as an
No,
newly described technique is giving as a subconjunctival injection before even cutting the conjunctiva? So did you do that? Because what you're trying to describe is very unlikely that the inferior injection of post-operative, at the end of surgery, what you have given as Genta and Dexa as a post-subconjunctival is causing the diffusion of the bleb like this. No, it is very unlikely. So what was the method of mitomycin C application peroperatively?
it was we applied with the help of cotton plug only
After making the conjunctival
after
flap?
making the conjunctival plate.
Probably your flap was too large then. What was the size of the conjunctival flap which was dissected?
It is not
Because
too
it's
much
very
large.
unlikely to have a bleb going from 11 o'clock till 6 o'clock. Very, very unlikely.
But madam, all the previously reported cases, they describe it occurs after average 9 months to 1 year. But in this case, in our case,
So that's what I'm saying. Yours is a very early case. So early case is indicating that something has happened intraoperative itself. This
So
is
I-
bleb
this is
tend to overhang over the cornea rather than spreading along the conjunctiva. So
Basically,
probably the conjunctival dissection could have been excessive. That is one thing which is coming to my mind. Since you have not uploaded a surgical video, so we can't come to know that.
yes, ma'am. I will critically review my video. Then it was just hypothesis, madam. It can make iliatic tract.
It's unlikely. Unlikely. It's probably your application of mitomycin C was excessive. Probably the amount was larger or your conjunctival flap was large.
Yes, that might be. Yes. Okay. Thank you, ma'am.
So our next speaker, hello, madam. Hello, madam. Just one second. She has another presentation with some other one. So that's right. Dr. Mundu will be presenting the next one. So could you just announce your, you can, use the, that's it, what is that? So that, we might request you to use that podium. Yeah, yes, thanks, Sasna.
Good afternoon, respected judges, and to all the persons, delegates present here. And today I'm going to present a paper on the topic was to evaluate the preoperative and postoperative intraocular pressure control following trabeculectomy surgery with mitomycin C at our department. So there was no financial support and sponsorship for this study, and due consent of the patients had been obtained. So as we all know, trabeculectomy is the surgery to lower the intraocular pressure by creation of a fistula between the anterior chamber of the eye and the subtenon space. So we basically, the objective of our study was to evaluate the preoperative and the postoperative intraocular pressure following trabeculectomy surgery with mitomycin C. It was a 1-year follow-up study done, and to determine the factors in case of failure. So we did a detailed ophthalmic examination of the patient, including the intraocular pressure, and the visual fields were examined, the optic nerve head evaluation was done, and the general and systemic examination of the patients were done. So in the inclusion criteria, we actually enrolled only 30 patients with primary open angle glaucoma and chronic primary angle closure glaucoma who were not responding to the peripheral iridotomy or iridoplasty, and those with poor glaucoma with poor intraocular pressure despite prolonged use of anti-glaucoma medication. So we did the study from January 2021 to July 2022. A 1-year follow-up was done, and the patients with poor compliance were also enrolled, and progressive loss of visual acuity despite inadequate IOP control were enrolled. We did not include patients who had poor visual acuity like PL positive or negative, if any other form of glaucoma or inflamed eye, aphakic or pseudophakic patients, and those who had previously failed trabeculectomy surgery. So these were our results. So we found that obviously the male patients were more accessible and they came to us more, and the number of chronic primary angle closure patients were higher in our study. The preoperative and the postoperative IOP study was done. In the preoperative cases, it was a bit higher, where it was a significantly reduction was seen after the surgery. The post-operative IOP measurement, we could reach the target IOP in 53% cases to 10 to 12 millimeters of mercury, whereas 33% could be like 13 to 15 millimeters of mercury. And mostly the post-operative IOP was in the range of 14 plus minus 2.1 millimeter of mercury. The factors which led to the failure of the surgery, on follow-up we saw that flat bleb formation was seen and an encapsulated bleb case was also seen. So in the discussion, in our study of 30 cases, we found that the mean preoperative intraocular pressure in the open angle cases were 26 plus minus 6.3 millimeter of mercury, and in the chronic angle closure cases it was 32 plus minus 5.2 millimeter of mercury preoperatively. After the surgery, it was reduced. For the open angle, it was 16.2 plus minus 3.3, and in the chronic angle closure, it was 13 plus minus 3.2. So maximum cases were of chronic angle closure glaucoma who were already on anti-glaucoma medications. So the failure cases, we found 4 cases of flat bleb and 2 cases of encapsulated bleb. So they were followed up at 6 weeks and monthly, and after the surgery also they were followed up on the day 7, 14 and 28, and their IOP was controlled, IOP was calculated. So on the left hand side, this was a case of a flat bleb in one patient, and on the same patient, the fellow eye had an ideal bleb. These were 2 of the failure cases which were seen. One had an encapsulated bleb and one with vascularization. So many studies have been done already on this topic, which have showed that mitomycin C augmented trabeculectomy have significantly reduced IOP. So we have seen that post-operative IOP control was good in 84% cases, and follow-up is still being carried out for these patients. The failure cases are also being followed up, and encapsulated bleb cases have not been revised yet. They have been put on steroids and anti-glaucoma medications. These are my references. Thank you.
Judges, please.
It's just a descriptive studies, so nothing to.
Thank you, sir. Thank you.
Can I ask only one question? If you're basically, you have taken open angle glaucoma, angle closure glaucoma, and made the three. Actually, there should be some standardization of this. Otherwise, there are a lot of mechanisms for angle closure glaucoma.
Yes, ma'am. We enrolled, like those who were already on anti-glaucoma medications for a long time, we were following them up with IOP and gonioscopy. So the chronic angle closure patients were.
No, that's not my question. Question is different. Question is open angle glaucoma
Yes,
and
ma'am.
angle closure glaucoma. So trabeculectomy you are doing angle closure glaucoma. There could be some other pathology there. You are just let
Yes,
the
ma'am.
mechanism be hyper.
Yes, ma'am.
Taken into account, cataractus case and all these things. So
Yes, ma'am.
standard of what do you think, sir?
No, so what was the indication in your cases of angle? What I was trying to ask is, what was the indication of doing surgeries in angle closure without even giving them a trial break? Because if your PI is patent and there is no significant thickness of the lens as cataractus thickness
Yes, ma'am.
natural lens is not increased.
Hmm.
So why not do a combined surgery or what, like was it the Eagle study and all this? Why not do a combined surgery? Why do only trial? There has to be some significant other. So was it a mixed mechanism glaucoma?
Yes, ma'am. Yes, ma'am.
It's a mixed mechanism glaucoma, then the other factors do come into
I
play.
think if you can separate it out, like you do the same study with open angle glaucoma separately and angle closure glaucoma separately.
Yes, ma'am.
With lens, I mean the cataractus status also you have to mention.
Ma'am, cataractus?
Yes.
Yes,
So
sir.
that is
Yes,
the,
ma'am. Okay.
you cannot compare like this open angle, angle closure, normal tension, all these things you cannot put together to show your success rate of trabeculectomy.
Yes, ma'am.
It was just a descriptive study, I think, because she never used to you didn't compare it actually.
No.
Yeah, that's why I said it's just a descriptive study. She just described her findings of all the patients operated for trial.
Thank you.
Thank you, ma'am.
Thank you, Dr. Murmu. So our next presenter is Dr.
Yes, sir. Yes,
Ankita
sir.
Sharma.
Okay. full screen.
Your time starts now.
Good afternoon, everyone. Today I would be presenting pupillary block following NDAC posterior capsulotomy laser for posterior capsular opacification, a case report. I have no financial interest to disclose. Pupillary block is a complication of NDAC laser posterior capsulotomy in pseudophakic eyes occurring immediately after the procedure or time after. It occurs due to disruption of the anterior hyaloid face and leakage of hyaloid across the edge of the IOL, which comes forward to block the pupil. It has been rarely reported in literature as capsular back fibrosis around the hydrophobic acrylic IOL edge prevents a direct communication between vitreous and the aqueous chambers. So our case, a 48-year-old male patient presented with right eye pain and redness for the past 5 days after having undergone laser posterior capsulotomy elsewhere. It started as a severe pain radiating to ipsilateral hemicranium. There was a past history of phacoemulsification with hydrophobic acrylic foldable IOL implantation in the right eye 1 year ago and in the left eye 1 month ago. The general examination was within normal limits. The significant findings on ocular examination in the right eye, the IOP was 36 millimeters of mercury as measured by Goldman's applanation tonometer. There was 360-degree circumciliary congestion. The anterior chamber was shallow peripherally and mid-peripherally with a Van Herrick's grading of 0. 2+ cells were present. The right eye's pupil was mid-dilated and fixed. PCIOL was in the back posteriorly, but the edge was in the pupillary area and there was a lasered PCO. So all these findings, along with nothing obviously seen to be blocking the pupil, brought us to consider to these differential diagnosis. So why it's a pupillary block? Because in pupillary block, the central anterior chamber depth is normal as the IOL is situated posteriorly. It's not aqueous misdirection syndrome because in that case, the whole iris lens diaphragm would have moved forward and the AC should have been uniformly shallow. In this case, we had not done an ASOCT or UBM, but if done, it will demonstrate vitreous in the anterior chamber or the pupillary plane in the case of pupillary block, whereas in aqueous misdirection syndrome, there will be a characteristic fluid in the suprachoroidal space under the ciliary body with anterior rotation of ciliary processes. On our B scan, we had got a normal B scan, whereas if it would have been aqueous misdirection, there would have been aqueous spikes in the vitreous. It's not hypertensive uveitis because the inflammation was not that much to cause an IOP rise. So a provisional diagnosis of pupillary block following NDAC posterior capsulotomy with stable IOL and good residual capsular support was reached. No aqueous pockets were evident on B scan and immediate management with acetazolamide 250 milligrams 2 tablets stat with frequent installation of atropine eye drops brought down the IOP to 25 millimeters of mercury within 3 hours. And then there was a continuation of acetazolamide QID with atropine eye drops thrice daily and combination eye drops brimonidine plus timolol. So next day, the congestion had not decreased. The IOP was 27 millimeters of mercury. Central AC was still deep and the nasal AC was still shallow. So a follow-up at 5 days, again we saw an IOP rise to 42 millimeters of mercury. The hyaloid was found completely blocking the pupil. So intravenous mannitol 300 cc was administered. NDAC peripheral iridotomy was performed and a sudden AC deepening was noted. So tapering doses of topical prednisolone and anti-glaucoma medications were given. This brought down the IOP to 22 millimeters of mercury with relief of pain. These investigations were found to be within normal limits at this stage. The patient was called at 2 weeks but reported at 2 months. The IOP at that time was 28 millimeters of mercury. Hyaloid was partly blocking the PI. A second iridotomy was hence performed and again deepening of the AC was noted. 15 days later, the IOP was 14 millimeters of mercury. Hyaloid was still blocking the pupil as well as the first PI. Steroids and anti-glaucoma medications were gradually tapered and the patient has maintained an IOP of 20 millimeters of mercury ever since. Comparison of OCT RNFL of the left eye and visual fields was stable over 6 months. So pupillary block following laser posterior YAG cap. It's first reported by Rudderman et al. In 1983. The vitreous comes into the anterior chamber and causes an intractable IOP elevation. It's a diagnostic dilemma because refractive index of aqueous as well as hyaloid is same. It's the most frequent complication following laser capsulotomy is a transient rise in IOP, maybe due to an obstruction of the trabecular meshwork by capsule remnants, high molecular weight lens proteins and inflammatory debris. So in patients with pseudophakia, transient increases in IOP are seen at the rates of 29 to 50% on the first post-op day in eyes with pre-existing glaucoma. Various etiologies have been proposed. It could have been that increased IOP resulted in a damage to the trabecular meshwork. A similar case was reported by Kersey et al., who observed pupillary block following NDAG laser capsulotomy in a previously subluxated IOL. So minimal energy should be employed, 1 to 3 millijoules per pulse, and 4 to 5 capsulotomy should be created always less than the size of the optic. Capsulotomy should be directed more anteriorly in pseudophakic and aphakic eyes. We should take care of medications like apraclonidine and timolol and acetozolamide either 1 hour before yak cap or immediately after the procedure they should be administered. Fixation of posterior chamber IOL should be in the bag. And in this case, a timely management with medical management, laser iridotomy, and a consistent follow-up helped us to prevent vision-threatening complications. These are my references. Thank you.
Judges, please.
Yes. Yes, ma'am.
With the permission of the judges, we will
Yes, ma'am. Suprachoroidal space. That was. Yes, ma'am. Yes, sir. Ma'am, it was not a diagnosis of aqueous. Yes, ma'am, it should be done. Yes, ma'am. Yes, ma'am. Yes, ma'am. Only the edge was in the pupillary plane. Yes. Yes, ma'am. Ji, ma'am. Ma'am, UBM was not performed in this case. Yes, ma'am.
thank you.
Okay.
Dr. Vidya Bhushan is there? Dr. Vidya Bhushan Kumar is absent. So our next speaker is Dr. Viraj Parwat. Dr. Viraj, please use that podium. Dr. Rashmi Kumar. Anyone? So only one more, Dr. Viraj will be there, and one more is Dr. Himani. Himani is it? Anyone else? No, they have not loaded the presentation. Yeah, please. Yeah, go ahead.
Yes, good afternoon everyone. My topic is prevalence and clinical profile of glaucoma in rural-based tertiary care hospital. I have no financial disclosure. So glaucoma is the second leading cause of world blindness with global prevalence of 3.54%. Prevalence of glaucoma in Southeast Asia countries is more, also in India also. So glaucoma studies in India have shown increasing age, high IOP, hypertension and diabetes as some of the risk factors for glaucoma. Considering scarcity of glaucoma studies in rural area of Western Maharashtra, this study was conducted to find out prevalence of glaucoma and its risk factors with aims and objectives of to estimate the prevalence of glaucoma and clinical profile of glaucoma in rural-based tertiary care hospital. This was the hospital-based cross-sectional study conducted in ophthalmology OPD in a rural-based tertiary care center. The sample size was 583 calculated using the following formula with 95% confidence interval. All patients above 18 years of age reporting to ophthalmology OPD willing to participate in the study were included, and those who were having juvenile glaucoma or congenital glaucoma were excluded from the study. Socio-demographic information was recorded, detailed history covering personal history, occupational history, history of any comorbidity and drug history was recorded. All patients underwent ocular examination including best corrected visual acuity, slit lamp examination, stereoscopic optic disc evaluation, fundus examination and IOP measurement with Goldman applanation tonometer. Suspected glaucoma cases on clinical examination underwent further glaucoma workup such as gonioscopy using Sussman 4 mirror gonioscope, and the angle was graded by modified Schaeffer's classification. Vertical cup disc ratio was measured and noted. A visual field examination was done using CETA 24-2 program on Humphrey's visual field analyzer. Optic nerve head glaucomatous changes were captured using OCT glaucoma scan. Operation definition is as follows: glaucoma diagnosis by any of the following three features like high IOP, significant disc changes and glaucomatous field defect. The data of the patients were tabulated and analyzed by SPSS software. So in results, in our study population, out of 583 cases, 42 cases had primary glaucoma. The overall prevalence was found to be 7.2%, out of which 90.4 cases had open angle and 9.52% was angle closure. So the mean age of the patient with glaucoma was 57.62 years. The prevalence of glaucoma was seen in elderly patient. Uh, there was no significant difference between the two sexes. The prevalence of glaucoma was found to be significantly associated with positive family history. All the patients who had positive family history of glaucoma were found to have glaucomatous changes. Out of 82 patients, 33.33% diabetic patient had glaucoma with significant p-value. Similarly, for hypertensive patients, the prevalence was 38.09 with significant p-value. IOP recording was available in all 583 cases. The mean IOP in both eyes was 14.42 mm of mercury. One or more disc features suggestive of glaucoma were seen in 61.90% of cases. Bilateral glaucomatous optic disc atrophy was seen in 2 patients and pale disc was seen in 2 patients. The loss of RNFL nerve fiber layer, RNFL thickness was seen in all 4 quadrants in 5% of cases, in 3 quadrants in 53% of the cases, in 2 quadrants in 4% of the cases, and only in 1 quadrant in 26% of the cases. Uh, visual fields, the mean deviation, the mild mean deviation seen in 78% of the cases, moderate mean deviation in 18% of the cases, and advanced mean deviation in 4% of the cases. There are not many studies comprising the automated perimetry and gonioscopy for confirmatory diagnosis of open angle and angle closure respectively. Hence, this study was conducted incorporating this examination. The prevalence of glaucoma was found to be 7.2% in our population of western part of Maharashtra in our rural-based tertiary-based study. The glaucoma prevalence rate was in our study was comparable with Vellore eye study. However, the population in our study was rural, whereas the population in Vellore eye survey was primarily urban. Increase in the prevalence of glaucoma with advancing age has been reported in several studies. A positive family history of glaucoma is a known risk factor for future glaucoma. We also observed a strong correlation of glaucoma with positive family history. So in conclusion, our study highlights a high prevalence of glaucoma in our field study. Its association with increasing age, positive family history, and history of angle closure may give us indication for early detection. Screening for glaucoma during middle age, especially among person with a positive family history, would help us early diagnosis and management of this irreversible disease. Being the most common irreversible cause of blindness, early diagnosis and management of glaucoma would yield a better prognosis. Thank you.
No questions? Thank you so much.
Thank you. Thank you.
So our last speaker. Presenter is Dr. Himani Jamal.
Yes, ma'am.
Anyone is left behind because lot of speakers have not given presentations. Anybody? So she is the last one. Yeah, your time starts now.
Okay. A very good afternoon to everyone. I'm here to present on a brief analysis of Rho kinase inhibitors side effects. So I have no financial disclosure. Glaucoma's only modifiable risk factor till now is intraocular pressure, and when patient's intraocular pressure is uncontrolled or in advanced glaucoma, conservative approach is maximum medical treatment. Rho kinase inhibitors are newly introduced anti-glaucoma medications, which included mostly in MMT. So these belong to a family of small GT paces, and they have their own receptors, that is ROCK1 and 2. These are found in trabecular meshwork. 3 mechanisms of action have been proposed. It increases trabecular outflow, it reduces aqueous formation, and it reduces episcleral venous pressure. So ocular hypotensive effect is the only reason why we uses ROCK inhibitors nowadays, but they are effective in lowering IOP, but the side effects have resulted either to continue them while the side effects resolves, or patient is counseled for it, or patient had discontinued its usage. So the common side effects are conjunctival hyperemia, blepharitis, subconjunctival hemorrhages, blurred vision, cornea verticillate, lacrimation, and corneal ocular irritation. So we have evaluated common side effects of ROCK inhibitors and their impact over glaucoma management. We have collected patients who were using ROCK inhibitors for more than 3 months. Their important data have been documented. Ophthalmic examination with glaucoma workup has done and side effects have documented. The treatment of side effects had done and their impact on intraocular pressure and medications have been evaluated. So in our case series, there were 12 eyes. Most common used ROCK inhibitors was rapasudiol 0.4%, that is in 8 eyes. Mean IOP when ROCK inhibitors was initiated was 22.5, whereas after 3 months of ROCK inhibitors, the mean IOP was 15.3 mmHg. So all eyes in our case series have side effects with ROCK inhibitors. 8 of them were using rapasudiol and 9 eyes were using netarsudil. Blepharitis and conjunctival hyperemia were the common side effects, followed by subconjunctival hemorrhage, nodular scleritis, and cornea verticillate. So the average duration when side effects appeared was 8.3 months, and total 9 eyes out of 12 where ROCK inhibitors have discontinued. So major trials on ROCK inhibitors have been done on mostly on open angle glaucoma. In our case series, it was angle closure glaucoma more as compared to open angle glaucoma. Blepharitis or irritant contact dermatitis is because of the hypersensitivity to active glaucoma drug itself or because of the preservatives. Blepharitis is concluded as common side effect by Tanhira H. et al. In 2-year study, whereas it is considered to be second common in a 1-year study by same author, that is Tanhira H. et al. Second common was conjunctival hyperemia, and we have seen in eyes who were using netarsudil. This hyperemia is because of vasodilatory property of the drug. The rare side effect which we got was cornea verticillate, and in our case series it was seen in eyes who were using rapasudiol. Other side effects were nodular scleritis and subconjunctival hemorrhages, which was seen in eyes who were using rapasudiol. So the mean average duration for the side effects to be appeared in our case series, for blepharitis it was 10.8 months, and for conjunctival hyperemia it was 5.6 months. We have discontinued ROCK inhibitors in total 9 eyes, 3 of them having blepharitis, 4 of them having conjunctival hyperemia, 1 of them having cornea verticillate, and 1 nodular scleritis. So conjunctival hyperemia usually resolves within few hours to 24 hours, but in our case series we have discontinued ROCK inhibitors due to cosmetic concerns immediately, and therefore no duration for its resolution has been noted. This is a before and after picture of discontinuing ROCK inhibitors we have in which it demonstrates resolution of conjunctival hyperemia after ROCK inhibitors discontinuation. So after an average duration of 1.75 months, AGM without ROCK have been started, and the mean IOP after 3 months of discontinuing ROCK inhibitors was 23.3 mmHg. 75% of eyes was advised for TRAB with MMMC. The limitations in our case series was the small sample size, short duration, and no proper statistical comparison. All eyes responded well by Rho kinase inhibitors, but due to side effects, Rho kinase was discontinued, and its effect on IOP even after other anti-glaucoma medications were not proper. Evaluation in terms of cost and quality of life as well as role of other AGM medications is needed in side effects. So either blepharitis or hyperemia, if present in patients, before starting ROCK inhibitors, they should be counseled and monitored properly. Using ROCK inhibitors once at bedtime instead of twice might helpful in reducing side effects with sufficient IOP control. These are my references. Thank you.
Why did you say one-sided? Rock will not act one-sided.
No, ma'am.
Hardly any studies on that. You can't take it. Maybe there's a take-home message.
Okay. Actually, I have attended one seminar. It was in Ahmedabad itself. There.
That must be one person's data. So you cannot, till you have long evidence-based
Okay, okay.
yeah,
But
not 100%.
okay. But with netarsudil, ma'am.